somebody who actually has heard of this before. And no, I have never heard of this before, but they all have the same problem. They all have problems with the spine, the hips, and the feet. Oh, yes, and poop. I spend more time in every office talking about poop, poop, poop. Anybody who's been in the office with me, nurses out there from the commission and whatnot, you know, and the therapists from the kids center, you guys know we're talking about poop all the time. It's crazy. So we're worried always about bone quality and muscle tone, but it drills down to those three areas primarily. I mean, you know, the knees, they're there too, the elbows, the hands, of course. But those are the things that kind of come into the forefront. So again, with the braces and whatnot, the 99% of the care is not surgical. The best thing we can do is look at the kid and find out what can we all do together. So I'm involved in a myriad of different multidisciplinary clinics. So that to me is the key thing, is being able to work together. Work together with all of you. All of you have identified yourselves as people who care. You care enough to get more education. You care enough to get more education about how to take care of kids. Therefore, you are part of the team. You're part of the team with your kids, and I think that's great. We can do surgery, but the best thing to do, just like for overuse injuries, is to prevent the need if you can. The support system goes on out. There are multiple different kind of specialists. Currently, I'm involved in multidisciplinary clinics with neurologists. That'd be me, the orthopedic surgeon, PM&R, physical medicine and rehab, neurosurgery, urology, endocrinology. I don't have a clinic with a cardiologist. I do have one with a pulmonologist. I also have one with, endocrinologist. Did I say that one? Yeah. Hem-onc, we don't work with directly as much, but we have a lot of patients that we share in common. And we need to get, especially psych. Don't we need pediatric psychiatrists around here? Anybody else think so? Somebody go get some training, please. Also with the various therapy specialists, they are absolutely so valuable to have in the office when we are seeing patients, but it's a waste of their time. They don't get paid for that. So usually when they're there, they're doing it out of the goodness of their heart. I have therapists that will drive from 2 hours away with their kid to come and sit in my office in the waiting room and wait for 2 hours to see me, and then get to see me for 15 minutes so that they can get that extra piece of information about their kid. I have learned more from parents and therapists than you can even imagine, not way more than I ever learned from a textbook. And the orthotists, we have the crazy advantage of having orthotists that actually come to our office and spend time there so we can have this didactic exchange of ideas, which is wonderful. And so having that ability to work together to help the kids is the best thing. So what's the difference? So again, simple categorization. When you have high tone, it pulls on the muscles. They're more likely to, the muscles can literally pull the bones right out of the joint. They can cause dislocations. They can cause different deformities. So when they have high tone, you got more problems, okay? You have more joint and bone problems. When they have low tones, you have less problems, but you can't fight gravity very well if you don't have any tone, right? So you have more difficulty walking. So we spend our days trying to make the low tone kids higher tone and the higher tone kids lower tone. So we're just trying to get everybody to meet in the middle. And the thing that takes a while to figure out is that almost every kid is both. So even in your high tone diplegic, spastic diplegic kid, they have low tone elsewhere. They have high tone in those muscles that are anti-gravity, that are pushing them up. But in all the other muscles, probably, they're low tone. So you take away gravity, and all of a sudden, you find out that they're actually weak. What about the difference in bone quality? So some syndromes have dense bone, relative osteopetrosis. It's not all osteopetrosis. Oddly enough, OI has dense bone, especially after fractures. They fracture a bunch of times, and anybody who's ever been in the operating room operating on a kid with osteogenesis imperfecta, the part of their bone that maybe hasn't broken at all or hasn't broken recently, you can take a butter knife and put it right through their bone, okay? But the part of their bone that has broken a bunch in the diaphysis of their long bones, we have to get drill bits and you go through drill bits. You need a diamond tip drill bit sometimes to get through the canal of somebody with OI or rickets because their bone is so hard. For somebody with soft bone, that's impressive. So just like the muscle quality, it can be a combination of two different things. When do we do surgery? Well, we do surgery when nothing else is working. They have a fixed joint contracture, so they can't be braced. A joint is dislocated, it won't go, you can't just pop it back in. If a kid with CP has a hip dislocation, don't send them to the ER, they can't pop it back in. That needs a big surgery to reconstruct it and get it back in. So when nothing else is working, we have to fix it. So that's why bother. We bother in order to get functional gain, to improve something, to make something more comfortable, to go from this level to try to accomplish getting to the next level up. So we try to do this in a timely fashion, single event, multi-level surgery if possible. This is for all those syndromes. Everything that I had up there, that whole big long list of them, we do the same thing for all of them. It's the same across the board, okay? So I can take all those things and I can make it into those various categories, but in the end, it's all the same. It's all about function. That's all that matters. I want to take each kid and squeeze every bit of function I can get out of them and make them as good as I can. Now let's talk about a few of them in particular. Amyoplasia or arthrogryposis, that's horrible, kinda, right? Nothing's horrible entirely for the most part. This baby has bilateral dislocated hips, bilateral dislocated knees, bilateral club feet, bilateral elbow extension contractures, can't flex or extend either or any of her fingers, and has shoulder contractures in internal rotation and adduction, and she can lift her arms up about like this, okay? But this is normal. This piece right here, normal. Normal brain function. Okay, so our job is to get this as functional as we can. She's never going to walk. This is a 17-year-old picture. So I know she's never going to walk. She's going to be in a wheelchair. She's going to graduate top of her class, and she's going to go to college when she's 17. This is tibial deficiency. This is the knee, you can kind of see a little crease there, that's the knee. The shin shank there is about 2/3 the length of the rest of the leg. This prominence here is the ankle, the distal fibula. So there's a fibula here, there is no evidence of a tibia at all. The best treatment for this is, to be honest with you, possibly in this kid, possibly would be amputation here, but probably is amputation here at least. But the family, understandably, it's a little hard to part with your kid's foot. There are 5 toes. 4 of them are normal, one of them's not really. But the family didn't want to get rid of the foot. So we did this instead. So we kind of straightened out the foot and stuck it on the bottom of the fibula, which is fine, except the knee's unstable. So it's not really great for walking on, but at least he can put a shoe on it, and it's a start, okay? So then this is me taking a picture to send to Max, the orthotist that we were toasting before. I said, I want a long leg brace, and I want there to be pressure here and pressure here to hold the knee in extension while you're pushing forward on the foot to hold it up. So we made this kid a long leg brace to hold all that together. And at this point, he's about 15 months old, and he's walking on this crazy looking leg. And then we need to do something to stabilize the knee, because if I let go of the knee right here, the fibula is not attached to the tibia, and it just shucks back and forth a lot. So eventually we got an x-ray, and there is a tiny white circle right here. I don't know if you guys can see it from where you are, but there's a tiny little white circle right about there on my monitor, and that's the tibia, okay? This is the fibula. It's giant and hypertrophied because that's the only thing he's putting weight on, but that little dot is the tibia. So we go in surgically, and we cut the fibula off here and move it over here and attach it to the little bottom of the tibia, right? Move it over and attach it with 2 pins. And in person, you can see that little bone of the tibia, but it's about the size of a marble, so this is kind of exciting. And then he comes back, believe it or not, this is 4 weeks later, comes back to get his pins out, and look, he's got a tibula. It exists. It's a tibula. So this is a kid with Marfan syndrome. This is not, what's his name, Austin, Isaiah Austin, that he was showing the picture of before. This kid's never going to play basketball. This is severe Marfan syndrome. There's everything. It has gradations. But so this is not going to be a basketball playing kid, but he has all the other features of Marfan syndrome plus the genetic diagnosis. So he has loose joints. Everybody knows the loosey-goosiness of Marfan syndrome, but what people don't realize is if your joints and your soft tissue's crap, your bone's probably crap too, okay? So he also has a higher risk of bone problems and fractures, and he has a horrible scoliosis, major issues there. Similar to Ehlers-Danlos syndrome, I got these pictures on the right off the internet. Isn't that just gross? His facial expression was really creepy too, so I cut the facial expression out. But, and this is the atrophic scar that they get with Ehlers-Danlos syndrome. So skin is the biggest manifestation with Ehlers-Danlos syndrome. They're also loosey-goosey, but maybe not quite as loosey-goosey in some of them as the Marfan syndrome kids. But this is a family, you know, the mom and the daughter. This is actually two daughters. This one is the same one as this one, and this is the daughter I was actually seeing, so she's got a gown on. But crazy hypermobility, and if you just examine the whole family, suddenly you find out that's part of that history thing that we were talking about earlier. So you find out, oh my goodness, look at that. Orthopedically, mostly they need those UCBs that from California braces on their feet, you know, and they need a little bit of support, but usually not much surgery until they get scoliosis, and then Dr. Meyer sees them. Constriction bands. I'm sorry these are a little fuzzy. No, you know, never ever carry your phone in your pocket without having a phone case on it, because then it rubs up against even just the fabric in your pocket and it ruins the lens on your camera. That's what happened here, just so you know. Word to the wise, okay? So all my pictures from that era are a little fuzzy. But this is great toe, second toe, third toe, fourth toe, fifth toe. So he has all 5 toes there. But 2 of them are stuck together here and 2 of them are stuck together here, and so they grow toward the, you know, away from each other. They grow toward the shortest of them, and so it caused his foot to separate like that. So we had to do a surgery to basically syndactylize the second and the third and try to cut these apart a little bit to keep them from growing back together like that. He had deepening of the web space here by Dr. Gupta to help him use his hand a little better, and this is his best hand. That's just constriction band syndrome. Here's a kid with osteogenesis imperfecta. Some of the typical findings, if you look at this picture, I tried to get it, it's hard, but his fingers are those long spindly fingers, but that's usually not described. People don't talk about that with osteogenesis imperfecta. They talk about that with Marfan syndrome, the spidery, long spindly fingers, but remember with Marfan syndrome, I said they have an increased risk of fracture. With Ehlers-Danlos syndrome also, that's a collagen disorder. Guess what else collagen is in? Well, it's in bone. So in OI, the bone is more affected, but almost every kid with OI has ridiculously loose joints and loose floppy skin, and they get those atrophic scars, but people don't talk about that part with OI, because with OI, the main feature is the bone. But really, they're all related. They all are part of the same thing. And so he has those long spindly fingers. He's got blue sclerae, he's got dentinogenesis imperfecta. These are not, actually I think these are his bones, and these are somebody else's bones. This is this kid. This again was at Wake Forest, and so this was 16 years ago, and pomidronate and stuff was not widely used back then, and so he didn't have the advantage of all that, which is unfortunate because he probably doesn't have that severe of OI today, if he were managed today. So different things that we can do for OI, we love sticking metal things in bone. We can usually make the bone stronger by sticking something metal in it, and we love to do that. Anytime you do it, there are risks and benefits, and so the best thing to do is if you think that could be helpful, you send them to us and we take a look at it. But this is one of the things that's best managed in a multidisciplinary clinic, because pomidronate can make this never normal, but a whole lot better, okay? This is a pterygium. Pterygium, like pterodactyl. Think of the wings of the pterodactyl, and they have that webbing between them. So pterygia is just a webbing behind the knee. Seems like you could just take a knife and cut that skin back there and it would all be good, but no, indeed, the most tight thing back there is the neurovascular bundle. You can cut the lateral hamstrings, the medial hamstrings, the gastroc, the knee joint capsule, you cut all that, you still got a problem because the nerve and the vessels are the tightest thing. So you have to actually cut the bone above here and shorten it up, and this one was so severe. This kid's only like 2 years old, I think, and he had a greater than 90-degree angle at his knee. And we got him out straighter, and he's walking now. But it's, this is a problem because he also doesn't have normal quadriceps muscle, so he can't pull his knee straight. So that's a huge problem. That's pretty orthopedically significant, I would say. And this next one is very orthopedically significant. This is a diastrophic dwarf. This is the cord from an ear looker otoscope, right? Just kidding. I know what it is. So this is at Wake Forest where we had to share these clinics with people. Wake Forest. Blah. Anyway, so she's you'd never guess it, and I think this is just incredible that she's 16. Relative to the size of that otoscope cord, that tells you she's like under 30 inches tall. So she can stand and she can walk a little bit. This is her foot. She had a little bit of a varus deformity of her foot, and this is called a hitchhiker thumb, where her thumb is so abducted, and she has a hitchhiker toe. So I had her put those. She loved having pictures taken of herself. She just loved it. She's all about it. So these are her bones, her little crazy little squarish looking bones of her hand, and this is a scoliosis that she's never going to get fixed because she knows that even though it would make her taller to have her back straighter, the risk is high because her bone quality is pretty poor. This is multiple hereditary exostosis, which is an awesome x-ray. Isn't that cool? So you can see on here all these huge tumors. So there's one sticking up here. The way you see this peeking in here, that means there's one sticking either straight out in front or straight out in back. Usually it's straight out in back. Look at this huge one here, binding those two together. There's a smaller one here. There's sticking right up here, over here, over here. So mostly with MHE, the tumors are most common around the knee, at the shoulder, and on the ribs, but they can be truly anywhere. It is hereditary. That's why they put that word in the name, right? So there's usually somebody else in the family who has it. It's got pretty good penetrance, so usually there's lots of people in the family who have it. Olliers disease is multiple chondromatosis. So this is osteochondromas or exostosis, X meaning outside the bone, exostosis. So this is multiple chondromatosis. So this is a tumor that grows inside the bone. It's a cartilaginous tumor. It's not cancer. It looks horrible though, right? It looks kind of similar to that diastrophic dwarf, but it's very different. And this is a leg film. Notice how the femur on the affected side is ridiculously long compared to the femur on the unaffected side. That might not seem instinctive to you. You would think that the affected side would be short, and you would be right. So this girl had lengthening of the femur because her whole leg was short. So we lengthened her femur so that, and over-lengthened it because she's only 8. So that's so that as she grows, the other leg will catch up. And then when she gets close to done growing, we would do a lengthening here to make things even at the end. And you can tell this is an old x-ray because we don't use those anymore. That's a staple. That's actually a bunch of staples at her knee. But the bad news is that when you lengthen it, it lengthens with the same crappy bone that was there to begin with. So it's still an chondroma bone. Charcot-Marie tooth disease or hereditary sensory motor neuropathy. When the mom looks like this, it's a bad sign. Okay? So this is the mom, and this is how the kid started out. And this is actually the day we took pins out of his foot, so he's not actually standing on it. He just set it on the floor. But there's a big difference there. So we can do a surgery and make the foot more balanced and flatter so it'll sit on the ground better. And this is much longer lasting. This may still be his future, though, and I tell them that. I say, we can give you longer, but if this is your endpoint, that's your endpoint. And that's unfortunate, but that's the way it is. But this is as much of a problem as this. So the girth there is a problem. I'm going to send them all to you, Dr. Neiman. Rickets, that's metabolic bone disease. So this is a kid that I see with Dr. Wintergers from our endocrinology clinic. The wideness, Amanda had one up there earlier, but you can see the difference. I think this one is a little bit clearer than the one she was showing, especially on the femur here. There's just this wideness here. Now, if all you had was a picture of that, of one joint that showed that, you might be like, oh, child abuse. Oh, that's a fracture at the metaphysis. Oh, child abuse. But it's not. It's here, 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 here. And this is actually her, but it was younger. So there's a few years in between here. But this distal ulna, this cupping, that classic where it looks like I don't know, to me it just looks like something you'd want to put a marble in and play with it. But, and it's excessively wide at the distal ulna there. So why do we do all this? Why do we take care of this stuff? I take care of this stuff because one day I'm walking into one of the medical office buildings at Suburban, and I walk in and I hear, X! And it's him. And he's yelling at me. That's as loud as he gets, you know. And he's got this thing. This is his communication device. And on that communication device, he has a map of the hospital. And he's a volunteer. He's telling everybody where to go. He knows everywhere to go because he's been there. He spends his life in the hospitals all the time. So he's a volunteer, and he tells people, isn't he proud? Look at his face. He's so thrilled to be there and be able to help people. And so I said, well, where's my office? And he's like, he can't talk very well. He motorizes, he just sets it up and off he goes, and he took me right to my office. And so the reason we do this, the reason I do this, is because it's things like that kid getting to be able to do something that he'd never been able to do before, just like she's never been able to do this before. That's this was a big move for her. She's 8 years old and has never spun in a circle. That's huge. Isn't that cool? What an accomplishment. Good for her. It just went to 0.